So let's get started with Dr. Alysse Wurcel, who's an associate professor at Boston Medical Center, that's going to be sharing her study involving a number of medical centers to look at their HCV and HIV screening of persons who inject drugs. Dr. Wurcel?
Hi, thanks so much. Hopefully everyone can hear me okay, and I'll share my screen. I was at Tufts Medical Center in Boston, right down the road, for about 12 years. And last month I moved to Boston Medical Center. I'm really excited to be asked to join you all and talk about my study, or our study. As you can see, it was, sharing. Oops, there we go. So I'm going to talk about the study, the Hep C testing in hospitalized people who use drugs. And I guess I'm just going to start off, like, do you ever feel like Sisyphus? And I understand this is every clinician, every public health worker has their thing that they're interested in. This is what brings us to medicine and public health. And, you know, my husband's a neurointensivist. He probably has things that he feels like Sisyphus about, things that are should be easy but are hard. Why is this boulder so hard? And my boulder is just infectious diseases testing as it relates to people who are incarcerated or people who are hospitalized, and especially people who use drugs. So this is a study that came out a while ago in Annals, and it basically shows how Hep C is passed and models what we need to do to stop Hep C from being passed. And although this is populations in prisons and populations in the community, I'd like you to sort of think about populations in hospitals and populations in the community. We don't want to think about hospitals as being institutions, but they definitely they're a separate entity from existence in the community. They are opportunities. They also block opportunities, whether it be jobs or spending time with family, or, you know, paying your rent or having a cigarette. Although as people who are interested in healthcare, it may be counterintuitive to think about hospitals as prisons. They're institutions that sometimes provide care when other people can't, and they're institutions that prevent care sometimes, or prevent the person from going on. So as it relates to people in the hospital, identifying Hep C, if you're in the hospital, is really important to stop the spread of hepatitis C. And this was an article that just came out in 2020, actually, I guess 4 years ago, which just sort of talks about how at least based on modeling, it takes a really long time to get people a diagnosis of hepatitis C. There's so many things that happen in their course of their life. And in this modeling study, it just sort of suggested about 4 years between infection and Hep C diagnosis. For most people who use drugs, especially in Northern America, or at least in the Northern United States, it's sort of like a known entity that you'll probably get hepatitis C if you share drugs within about a year, probably less, just because it's so prevalent. But there is a delay in definitely getting diagnosis, especially of chronic viral hepatitis. So what are the systems at play to prevent Hep C testing in the inpatient setting? I know there's problems with the socio-ecological model. I'm just going to build broadly off of it to say, there's individual knowledge, attitudes, and skills, whether it be the clinician or the nurse that thinks that the inpatient setting is not the right time, that Hep C is an outpatient issue. There are interpersonal, family and friend and social networks things where people who use drugs don't think Hep C is a big issue. There's a article about this that says Hep C is the common cold. Why should we, you know, I'm trying to work on someone and prevent them from overdosing. Why would I waste 5 minutes of my time even discussing Hep C when I could use those 5 minutes to better discuss overdose risk or better discuss other tools of harm reduction? There's organizational goals. I think, you know, as it relates to Hep C treatment and initiation, it is counter to the hospital finances to treat and test Hep C. It is counter. It's the same. If you find something, you have to deal with it. And now you found Hep C, but you're going to tell the person you can't pay for their Hep C treatment while they're hospitalized. So I think it really goes counter to the model, what the hospital wants. In the community, and even as it relates to public policy, you know, how we continue to marginalize and make people who use drugs as the other. They're the other, the undeserving, the people that are dehumanized and don't deserve good care. So I think all of those things probably coalesce into why inpatient Hep C testing is not prioritized. And I've been guilty of this too. You know, if I'm on the ward seeing someone who just overdosed or has massive endocarditis, you know, the idea of whether I'm not going to counsel them about Hep C, maybe that I've been guilty of this too. This is not, I take responsibility. So, you know, I'm up in Massachusetts. We've had HIV outbreaks. I've diagnosed so many people with HIV. I continue to diagnose so many people with HIV. We have intense drug overdose rates. I know we are happy that overall the overdose rates are going down, but there's still way too many overdoses happening. And then we are one of the sites in Massachusetts that has done some of the really, everyone's doing great work. We've been able to do sort of look at who these new cases are for Hep C, where are they happening? And we know that people who inject drugs make up the vast majority of people who are getting hepatitis C, at least right now. So, and then we also have this integrated viral hepatitis surveillance and prevention program, and I benefited from this, and I work with a Mass DPH, and so Massachusetts is one of the sites that's really tracking hepatitis C. I wrote this paper where I tried to implement a bundle to improve HIV testing during hospitalization for people who inject drugs. I'm using this as just a background to show that I've been trying to do this for a decent amount of time. We came up with something called the ABCs of care for people who use drugs, which is test and vaccinate for hepatitis, test for HIV, offer MUD, and prescribe Narcan. We came up with buttons. You know you're legit once you come up with a button. And then we actually came up with a jingle related to Michael Jackson's ABCs. And we made a YouTube video, just trying to get people to engage in this sort of bundled approach to care for people who use drugs. That leads me to this paper, which was just published in Open Forum Infectious Diseases. I want to tell you this paper had no funding to push it forward, so it's just based on the grit and the interest of the investigators. To get anyone to agree on anything is really hard, whether it be Dunkin's versus Starbucks. So you can imagine, like, to get all these people to come together on methodology and to write a paper, it was sort of a monumental feat. So I'm so lucky that I got to work with them and this idea came. But the reason why we did this paper, the reason I was interested in doing this paper is in Massachusetts, you need consent to test someone for HIV. You do not need consent to test someone for hepatitis C. And actually, Massachusetts has some of the strictest rules of the whole country as it relates to HIV information, all prepared in the context of people who were, denied health insurance and denied things back 20, 25 years, 30 years ago when they were diagnosed. But I thought it was interesting to look at the different states. So these are the states that are involved in our study: California, Texas, Colorado, Missouri, Alabama, Illinois, New York, Vermont, Maine, Connecticut, and Massachusetts. So we have a wide breadth of states. I just put up there their HIV prevalence. So you can see their different prevalences of HIV, with California, Texas, and New York being one of the higher ones. But that's what, this was our group of researchers that we came, and people are like, well, how did this happen? How did you choose these states? I wish I could say there were robust research methods. It's just interested people who had time to go to their IRB and to get data or already had data sets already existing. Okay, so this is table 2 from our study. It is entitled HIV and Hep C testing and positive rates in people who use drugs admitted to 11 hospitals and hospital systems. And so on the left, you can see all the different hospital systems and the number of people who use drug admissions. And, you know, the N is very, Parkland Hospital likely had more people who use drugs admissions than Claire, but each hospital contributed the data set that they were able to have. So some places contributed a data set that they had for all of the addiction medicine consults. Some people, like at Tufts, I was able to do a review of all of the admissions. So they're not the same cohort necessarily bringing to the table, but each was able to bring to the table people who use drugs. You can then see after that, the number of HIV tests completed was incredibly variable. So for example, at Barnes Hospital in Missouri, 41% of people who use drugs had an HIV test. In Montefiore, it was 17%. At my institution, it was 24%. Certain places like San Francisco General Hospital is 78%. So there's incredible variability. of who uses drugs and who gets an HIV test. I was interested specifically in whether the idea of verbal consent required had an impact, and it did not, at least on like a broad chi-square kind of approach. Whether or not verbal consent was required to do HIV testing, at least from this study, did not clearly impact HIV testing. And then hep C testing in these people who use drugs admitted to the hospital was either the same or lower than HIV testing, which kind of ran counter to what I thought would happen. I thought there would be more hep C testing than HIV testing, because hep C does not have the same sort of discussions mandated around it. There were some problems about that, and given that like maybe a lot of people said that they had hep C, so they didn't get a hep C antibody, and they would get a hep C viral load as well. But a lot of people who use drugs are not getting hep C testing, whether it be antibody or viral load completed when they're in the hospital. And then lastly, you know, at least when I was at Tufts, reflex hep C viral load from antibody testing was not possible. The amount of time and energy and that went into discussing why this was not possible, amount of meetings, I don't understand it entirely. It's about number of tubes and billing and all these other things. I guess if there could be anything that could come from a policy change, it'd be that all hospitals need to have this available, that I have a positive hep C antibody would reflex automatically to a viral load. It feels like the right thing to do. I'm not sure why some systems are able to do it and some systems are not. I know it's way more complicated than that. There's lab techs and lab to inlets, but there's a lot more there. So I guess I just want to take home the message of heterogeneity. There's total heterogeneity across how we manage people who use drugs, and not just heterogeneity, but we're not testing people for HIV and hep C the way that we should. And in order to stop the epidemic or curb the epidemic of HIV and hep C, we need to diagnose these people. It is our duty, it is our job to diagnose people, both because it's their right to know, and also because it'll help slow the spread and stop impacting people in the same way. So with that, I'd love to collaborate. This is me, Alysse.Wurcel@bmc.org, and I'm so appreciative to be asked to be part of this.
Thank you very much. I really appreciate you joining us today. That's a very recent publication, and so I encourage everybody to go take a look at it. I was really struck as you were mentioning how oftentimes the proportion test for hepatitis C was lower than that for HIV, yet the prevalence of the infection was much higher for HCV than for HIV, and it's, I wonder why that increased positivity rate is not driving more testing. Do you think the injection drug use is not being picked up by the clinician? Or are they asking people, have you been tested? And people say yes, so they don't test again. What do you think are some of the reasons for this?
At least in the people who have been admitted to the hospital who use drugs, it is not a shock. Like they're coming in with rip-roaring endocarditis. I mean, I do think there is probably an iceberg situation that we're just seeing. Like there are other people we're missing that we should diagnose, probably younger people, I would say more on the pediatric side, who we maybe don't know are using drugs. I just think it's a priorities issue. I think hep C is an outpatient issue in so many other people's minds. And I said, I want to take ownership of this as I treat people with endocarditis, and as, they're throwing off septic emboli and fevering, discussions about hep C get pushed to the wayside. And I think we're clinicians trying to do our best. There's so many patients to see, they're increasingly sick. And somehow the hep C stuff just gets pushed down to the wayside, or they say, yeah, I was tested and that's enough, that checks the box. Just sometimes you don't even know if the patient will survive to the end of the hospitalization stay. And that's why for these very sick patients, I think hep C just doesn't come up the same.
Thank you. Thank you so much.